Just so they get their blood excretions. But, you know, we used it for years and years and years. I don't know of any patient personally.
A lot of people that have chronic otitis for years have sensory loss. And you don't know, was it the infection or not? But remember, every one of us in this room probably had 3, 4, 5 times we had pus in our middle ear as a kid. Somehow the cochlea is very well protected. So, you know, I'm not sure why chronic otitis has so much sensory loss when they get older. Nick, were you going to say that?
Yeah, I mean, I feel, despite the experience that we've had with it, I think we did use it a lot. I used it a lot when I was a resident. Right? I think we were probably killing a lot of hair cells. I think we were. You know, you look at some of these patients who come in with aggressive, high-frequency sensorineural hearing loss, and you say, well, it's the otitis. I think we see less of it in the syndrome.
Yeah.
And I do still see patients who come in on Tobradex or some other kind of neomycin-containing drops, and they've got that high-frequency loss.
Yeah.
People write it off as part of the otitis.
That's
But
right.
I personally have had a patient, I remember this is a real changing point in my view. And I was just out of fellowship in Boston. I gave him Tobradex, and he would press on his ear and push it through the tube. And he became very vertiginous, and it took a long time for him to recover from that. So I would say we have too many other alternatives than to be using phototoxic medications in the corporation.
But you put it in the serious risk category as opposed to the minor?
I would put it, as an otologist, I put it in the serious risk category because
Yeah.
that's something that I think is avoidable. And
Neomycin is like the most phototoxic drug potency, milligram per milligram, and we're sticking it in the ear. So if you look at the aminoglycoside series, gentamicin preferentially the vestibular side, neomycin preferentially cochlear, tobra is kind of in the middle within a casein. When do you culture chronic drainage? I don't want a long discussion because we got a lot to cover, and we're halfway through. So how often, you know, what specific indications do you have for getting a culture?
It is absolutely fail my initial cleaning and toxin drops, so second time.
Okay. Any difference from that?
If it smells bad, I culture it, even if it's initial drainage, because I've been fooled, especially with immunocompromised patients that we see here at the Institute. And I was glad about it, I did.
You get a lot of scary stuff with your culture.
Yes, you do.
Okay, so all right, you get Pseudomonas or you get MRSA, right?
Yeah.
Now what do? You still got a draining here. So let's take, first of all, treating Pseudomonas in a child. So Alan, you've got Pseudomonas draining out of an ear, you've tried everything topically. Are you comfortable with fluoroquinolones?
I don't, again, no. I don't usually use except topically.
Do you operate on them?
Well, usually they take a couple rounds of cleaning.
And they get better. What if they don't get better? Do you operate on them?
No, I mean, it would take several failures for me to get IV concentration.
We just put them on fluoroquinolones. My experience. Because they use it all the time, it seems to be in the hematologists malignancies. Yeah. How about MRSA? What do you give them if they have MRSA? Not rare in chronic otitis.
I go to add either Bactrim or clindamycin.
Yeah. Go to systematic. Anything different?
MIC of these medications increases if you increase the concentration topically. So I've had better luck with putting a wick. Putting a wick in these ears, the contact time of the medication with the infection increases significantly.
Good
And then I would also increase the dosage to 4 to 5 times a day.
Oh, really?
So 5 drops.
750. This is adults, of course. 750.
No, I'm not the tablet. Just the drops.
Oh, the drops.
Yeah, like anything with the Ciprodex like that, 5 drops, like 5 times a day with the wick.
All right.
Makes
Okay.
a big difference.
Headroom. The mastoid bulb. Just that's what you see when you look in. Where's headroom?
Right.
There you are. What do you think that is? Okay. What species? What genus? Yeah. Right. It's black. Aspergillus nigrans, right? Yeah. Okay, so this gets down to what do you do for, somebody who comes in draining, you clean them out, you put them on antifungals, do you paint them with gentian or castellani's, do you flush them with vinegar and alcohol? How do you handle this? Amanda, you've got to see this down at Santa Clara fairly often.
I think this down on here.
You know what's interesting? Nobody was doing it. And I got to give credit to Frank Reiser. from Warren, Ohio, and said, you know, I don't have a problem with gastric bypass. They use this old style thing. They use boric acid and alcohol, and then vinegar and alcohol. And I started doing that. This is years ago. I said, God, it's like magic. It's wonderful. Now people are using it a lot more. It's in all the 19th century textbooks. They kind of knew what they were doing back then. They just flush it. Not drops, but flush.
Yes.
Anybody use paint, gentian violet or Castellani's, George?
Yeah, sure. Nick taught me that.
I do too. Nick, any difference in this?
Yeah, I think gentian violet works great. You know, you can keep it here dry. They don't have to put drops in it. Lasts for months potentially.
My wife hates the laundry bill though.
Yeah.
You gotta be careful.
Well, you gotta wipe it off.
Do you
Gets
guys
on a
use
white silk
like
shirt.
the pharmacy?
I bought an awful lot of lab coats when I was younger.
All right,
Rob,
Grace.
do this vinegar and alcohol flushes also for just fungal OE as well?
Oh, yeah, absolutely. Granular meningitis, the whole 9 yards. What you don't, it's different. If you have exposed mucosa, it hurts. Right? So if there's a hole in the drum, generally no. But use it for all sorts of things. It's magical. And you know, basically what you're doing, you have, you know, weeping, like when you scrape your knee, there's protein and stuff. It feeds the bacteria and the fungus. So it's an ecological treatment. What you're doing in flushing is you're agitating out the mud. The alcohol, they use a hairdryer under low power. It pulls out all the aqueous layer. The alcohol kills things. And it leaves an acidic residue because, of course, alkaline is bad. And it creates an environment, an ecology with the bugs don't live. Yeah, it's really effective. I see OMD nodding her head because she's seen it. Grace, on antibiotic eardrops for 3 months, 5 different drops, not improving. You see this ear person coming in, it's just not getting better. Where's Grace? Oh, there you are. So, what do you think that might be when you look at it? Can you describe it? What color is it? Kind of yellow, kind of white, what kind of texture? Yeah. What could you hazard a guess after 3 months of drops not getting better what that might be? Want to phone a friend? Anybody named Candida here? Candida? Yeah, that's Candida. And you know, we see this in admit of 5 doctors and 6 drops and 7 courses, and it's just that it's got yeast overgrowth from all the antibiotic treatments. So what do you guys do for Candida otitis? You can culture it and you'll get Candida. But you just see that it's like cottage cheese. It's pretty clear. It's sort of a beefy redness, kind of like you see with thrush. Any thoughts? Nick, how do you handle it?
Stopping the antibiotic drops. I think, again, acidic drops, vinegar and alcohol as well, in patients also.
Yeah.
You know, so it's same antifungals. Occasionally I'll put people on oral antifungals, but it's really
I get a fasting blood sugar on these patients too, because it can be a precursor of early diabetes.
Lotrimin.
Yeah.
Right.
Yes.
Right.
Yeah. Although I agree, usually just cleaning out the ear and flushing takes care of it. This is the universal cure for these kinds of things. It's stopping all the antibiotic drops so that the normal flora occur within the ear canals. So you guys use powder? I mean, we have this at the Ear Institute. This is, thank you, Jennifer, for holding this. This is boric acid and nystatin. Certainly, after I cleaned out the white muck, I put nystatin powder in. I use a lot of boric acid powder in healing bowls and things. Just the question is, do you ever send patients home with a powder spray? I know Jim Sheehy used to do that a lot, and I used to have to clean out the caked up mess that built up. But so, anybody use it at home? Do you ever send patients at home with the so-called dry treatment, right?
Yeah.
The powder? You do? What do you do?
Yeah, but it's hard to get hold of. You have to find the specialty pharmacies that will compound it for you. But I've had modified radical mastoid cavities that just will not respond to anything. And they say, I had the surgery at Dr. House's in Los Angeles, and this is what he gave me, and now I get it from the house group. Can you give it?
So that's
Sure.
the amphotericin powder.
Yeah,
Yeah.
that's it.
That's amphotericin.
Yeah,
Yeah.
that's right. CSF, right.
Chloramphenicol, sulfanilamide.
And-
Yeah, we're talking about the history of antimicrobials.
That's right.
No, but they had an ampho one there when I was there.
Yeah.
So if you Google Aspergillus ear infection, any guess what comes up? in Google Images, that's what you get. All right,
Excellent.
Reza. Where's Reza?
Doctor's opinion.
Oh, you have to go. Brian. Dan, notice I've been hitting senior residents, right? So I get to go a little more junior. What do you have? What do you see, first of all?
It's a right.
Actually, it's a left.
Not the left.
That's how you have a 50-50 shot. So I remember we used to give at UCSF, you know, when the students in third year, they showed a picture, this is a right or left ear, and I completely thought that was crazy, because if you're looking at somebody, you go, yep, the nose is there. You know, that's not real knowledge, but it happens to be. But you see something down here.
Yeah.
Right? What do you see? What color is it?
I see reddish, violet, discoloration of the TM and or.
You want to do a myringotomy to see what it is?
No, do not.
Do you know what it is?
It could be a high range.
That's what it is. Good call. Okay, a little tougher here. Pedro.
Well, that's like the entire middle ear appears to be focused on something.
Very,
Reddish
very
brown.
perceptive of it.
That's hemotemperature.
It's a hemotype. This is classically described as gunmetal blue, right? But this is not someone who's just been in a car accident. Somebody walks in with a stuffy ear, can't hear them. It's so-called idiopathic hemotype. You see now and again. Anybody want to comment on that?
Barotrauma usually.
Can be.
Yeah.
They will tell you they've had barotrauma. It's very painful. But I'm talking about someone who just comes in clogged up. Certainly you see it in people who've had a temporal bone fracture, etc. But this is a spontaneous hemotype.
Doesn't cholesterol granuloma look like that on the left?
Yeah, this becomes cholesterol granule. It's in the
Right.
spectrum of that. Exactly. It's a chronic seeping blood within the miliary mastoid. Any thoughts about treating this? I know, Nick, you've seen it.
I think, well, in the absence of other symptoms, these will usually just go away. And people have a spontaneous rupture in the ear, wait to watch. But people who have recurrent otitis, people who continue to have bacterial loss despite a couple of months, that they probably have cholesterol granuloma.
In the mastoid, typically, right? So some exposed marrow.
You can put a tube in or drain it out, but in most cases, I would.
That'll be thick. Right?
Yeah,
This is the cholesterol granule one.
I would be pretty conservative about that, just because.
So I usually open up, I look at CTs looking for areas of erosion. I've seen it from the tegment with a little vein. I've seen it from the tip of the, you know, you go down into the tip, you go through the cells, there's a lake of marrow. Sometimes that's sort of seeping up. Somewhere something's bleeding on a chronic basis. Like a chronic nosebleed, except contained. Okay, Shannon. Where's Shannon?
It's down from inpatient for
Then Brandon, thank you for telling me. This is another one that's a little bit less common. What do you see and what would you call it?
on the left-hand side, it looks like there's contraction pocket.
Same patients,
And it
10
looks
seconds
like
apart.
The patient's valsalva or blood out against
Right.
expression earlier. I'm not sure what specific.
And
maybe connective tissue.
when they're like this, they swallow and nothing much happens. It doesn't deflate, right? So what that eardrum looks like, it's extremely atrophic, right? It's
Maybe
not
a
electronic,
eustachian-
but it's not stuck.
Eustachian tube issue, or Papulis.
Could be, could be. So this is, Jakob Sade Israeli named this hyperectasis. And what it comes from usually is from alternate habitual sniffing and inflation. And they're kind of, just think about work hardening the eardrum, right? Back and forth and back and forth. We've seen some in the last couple of years like that. This kind of finding. How do you treat this? Ahmed, you've seen this, I'm sure.
Not a cases. No.
Yeah.
It depends on the patient's symptoms. Right? And if there's no keratin degree in the pocket, you can watch it if the patient is having it. The question is, what is this doing to the patient? If it's causing hearing loss, if it's real operating, I would operate. If the patient is hurting, I would consider operating. You also need to look at eustachian too and see what they're doing to eustachian too.
Sure.
I would
So-
just go with the patient's and
The patient is telling you that their ear feels stuffy and full all the time. If you ever had a stuffy full ear, it doesn't feel very good. They really don't like it. It's that kind of full feeling. And they try to relieve it you ever know if you overinflate your eardrum coming down in the plane, it feels just the same as when it's sucked in. I mean, really, eardrum feels the same way sucked in or pushed out, I think. So anybody ever gone in and excised it and put cartilage and grafted it? I have a few times.
Yeah.
You've done that? Yeah. But this is not a well-described disease, but it's pretty much in people who picture the stiff. Well, typically the posterior eardrum. So let's talk about a common problem. Patient comes in, says, my ear's stuffy. How do you differentiate a Papulis tube, which is less common, from Eustachian tube dysfunction or hypofunction? What are your tricks to discern between overly open and overly closed?
I have the patient bend over and ask them if their ear feels better, or I have them lay flat and ask them if their ear feels better.
So hang their head between their knees?
That's correct.
And what's the theory of what happens if it gets better with their head between their knees? What's going on?
I honestly don't know, but I know what I tell them. I tell them that they're temporarily shifting the angle of the tube and getting some congestion and restoring the support of the sublingual pharynges, but I don't know. I honestly don't know.
Sublingual pharynges. Whew. I'd almost buy it. So, so any thoughts? How you tell them? This is an important problem, right?
This is very important.
Because if you treat it, you give them decongestants, they get worse, right? What do you think?
This is very good.
Oh yeah, we'll get to audiology. It's a good one. Got me out of here. But
Yeah, I think what George is saying, we often hear from the patients also who have Papulis eustachian tube chronic disease. They wake up in the morning, they feel better than
Right.
they go through the day. And it's probably just a head position, congestion around the nasopharynx.
Yeah.
Um,
and they don't have trouble flying.
often a lot you see.
Through their nose.
Deep nasal breathing, where we send to the audiologist, we do anagrams over time, and we see a little as close to seeing
See the baseline. Matt, you want to explain?
Yeah, I mean, normally with the panogram, we're applying pressure and basically observing how much sound is bouncing off the eardrum. And from that, we can infer eardrum movement. In this case, instead of rather applying it, basically you kind of just let it sit and let it run. Over credit. Exactly. And see and through looking at that, we can get a sense whether this is a Papulis or not. So.
Yeah. So you can put them on an impedance meter and just measure and see the respiratory fluctuation.
Exactly.
But yeah, I mean, it's important to recognize when you see someone come in, don't always think. I mean, ask them if it gets better or worse with colds, whether they have trouble flying. If they tell you they just do great flying, sometimes, of course, they will have autophony, and then that raises all sorts of other questions these days. Now, Jennifer's not here tonight, I guess, but she's our, and Hamid has quite an experience with ballooning. In plain old Eustachian tube dysfunction, we could spend an hour on this, maybe we will in the coming year or two. Does it help? People with stuffy ears that have trouble clearing, airplane pilots, flight attendants. You put a tube in, or do you?
No, I've had excellent results with dilation in those beta trauma otitis patients. As long as you don't dilate somebody with Papulis eustachian. That's the key thing.
Yeah.
And also, there's a subset of patients I believe that they alternate between this obstruction and Papulis.
Oh, really? Huh.
And these patients are really difficult to manage because some of them, like 70% of the time, they're obstructed, 30% of the time are open. Those patients you shouldn't dilate either because I think they'll be very unhappy.
We have about 15 minutes, and I want to cruise through a number of topics. I think it's great to touch on a lot of things. Anybody explain how the heck these things work, and do you recommend them to your patients? These are heavily sold in airports and all. Anybody recommend them?
Yeah, my patients swear by it. Not at it, they swear by it.
I think it's an Israeli thing, isn't it, Yona? Israeli company. I don't really get it. But,
Created two cavities. I don't understand why they work.
yeah. Okay. I gather you don't recommend it. So atelectasis without infection, in and of itself, the major issue is hearing, right?
Yeah.
Would you ever operate on this ear for hearing? You can see maybe we have an attenuated incus. Would you be willing to, somebody has a 30 decibel loss, maybe the promontory is here. Would anybody operate on that to try to restore hearing? I know you balloon dilate.
Yeah, I guess.
That's too late for that guy.
Right.
I think both.
Anybody would operate on that, or would you give them hearing aids as long as they're not infected?
Hearing aids ain't a prognosis for surgery here. Limited.
How about this patient? 30 decibel loss. Would you do that? Well, you clearly have tubal function in the anterior middle ear. You would go in and put in cartilage?
I do
You do that one. Everyone agree more or less with that? Okay. Ear trauma. We're going to get to peds in a minute. Okay, traumatic hole in the eardrum. Do you use drops? Let's see a show of hands amongst the panel. How many use drops? 1, 2, sometimes. Yeah, I don't usually use drops. Do you put a patch on it? I mean, acutely. If it wasn't healing in a month, you might. And when you put a patch, you use zigzag paper. I actually wrote this in the paper once. Rice paper, quote, zigzag company, Seattle, Washington. Or do you use Steri-Strip for your paper patch? Steri-Strip?
I use cigarette paper.
Cigarette paper? Additional.
What I used to do, oftentimes there's a fleck of skin associated with that. It's curled up under the edge.
You bring it up.
And if you bring that out, take a little piece of blood, pull the skin out, and put more blood on top of that. It's a nice little technique.
We all agree that will almost always heal, especially when really red and swollen. That's beautiful to see that redness. That's what you like to see. One thing is, in Latin America, they use the vitelline membrane of an egg. They have the patient come in with a boiled egg. I'm not making that up, and I don't know who eats it after you've used it. Okay, these are real quick questions. We're going to fly through this. Flying after ear surgery, tympanoplasty or stapedectomy. 2 weeks, 4 weeks, 8 weeks, or no restriction? 4? Anybody different? Roughly 4? Longer? Longer than 4? I do about 3.
I say 8 if they can do it, but maybe the first 2 weeks.
I generally tell them to do this sort of stuff. You can fly whenever you feel up and flying.
It always does.
Usually about 10 days, 2 weeks.
Yeah, about 10 days. Actually, it's the first week or so they've got all gel foam and fluid, which is non-compressible. It's when they start to pneumatize. Yeah. Okay, after tympanoplasty or stapedectomy, obviously, if you get down to depth and that eardrum ruptures inward, cold water flushing, you get a caloric, you vomit in the regulator, it's not a good thing. Do you let people, what do you tell them when they've had the tympanoplasty? You tell them they can scoop up or not? Anybody who says yes, you put it on them? Because
I would tend to tell them, find another sport.
How about snorkeling? Going down 5-10 feet on a coral reef?
That's fine.
That's okay.
That's fine.
It's useful. How long off CPAP? This is for you, Robson. How long off CPAP?
After your surgery?
After your surgery.
How long I put them on spot again? I would ask them for at least a month.
At least how long?
At least a month or
A
2
month or so, Stanley, you think? I know you haven't done much ear surgery lately. Pediatric otology. Okay, this is a good one for Alan. Drainage through a tube that's stubborn. So just assume that's just a draining tube. What tricks do you have to stop it?
Well, eardrops after eardrops.
And it's still draining.
I don't usually bring them in for IV antibiotics and then sort of stick the tube out.
Take the tube.
That's right.
Do you ever, and it still drains through a little hole? Do you do a mask one? So this you don't do anything about. But somebody comes in like this, or somebody comes in like that, how do you manage them and when? This is a pre-auricular pit for the junior residents.
It looks infected.
Would you operate on this? Or would you just treat this, if it kept squeezing out a little, it's not enough, unless it's happening all the time, or would you still operate?
I would do that.
Medically
See how
only?
many episodes they have.
One episode like this, would you IND that? You notice there's like surgical tape around it. Which actually probably, what's in that is dirtier than what's in the hair.
That's right.
Yeah. So,
Jeez, they're draining.
so you would drain it, and would you then operate electively after it calmed down? Or would you make it do it again?
After one infection, I usually recommend
One like that, as opposed to an infection.
I typically don't drain these things because once you cut into it, and you go back in to operate, Yeah,
You have to take
you
the
have a
skin.
hard time
Yeah,
finding
good
the
point.
entire
Yeah,
tract.
because when I see them, it's been like that. It's been IV'd 3 times. So I just take out the skin and I go all the way down to the temporalis muscle. I just take out everything. We don't try. It's like the dermatologist saying, you've got a ruptured sebaceous cyst, they don't dissect it out. They just wedge it out. Okay, Michelle. Where's Michelle? There you are. What's this abnormality? 100%. Okay. The family says, my son likes to play football. Alan, what do you say about contact sports to your kids with inner ear malformations?
Give you 3 good reasons not to play.
Concussion.
One of these.
2 years of concussion.
Of course, I don't recommend contact sports.
He wants to play chess.
But there's a risk, right?
So my 3-year-old keeps tumbling and bumping into things. What am I supposed to do?
Discuss the real risk of progressive and fluctuating hearing loss with this abnormality. Any contact sports, even soccer, can potentially cause this to happen.
And it's okay.
It's less likely.
Soccer without hitting your head, I suppose. A lot of times it's a 2 or 3-year-old who's just tumbling and bumping into everything. They lose a little hearing sometimes. Julia, site diagnosis, what is this? I gave you a hand. It's Dutch.
It's a
I saw
Wordmark.
that. You had a friend who phoned me over.
Sorry.
Go ahead, David, you're with it.
It's Wordmark.
So they don't usually bite you like this, where they've got the whole thing of the heterochromia, the synorphus, and the white forelock, but the blue with the blue eye. Right? Well, this raises, so when you see that really blue eye like that, think about it. So this raises the question of genetic testing. I think I'll turn to Alan as our greatest expert on this. When you get it, do you send out the full panel like this to one of those centers like Iowa or back at Partners? Or do you just do connection? Non-syndromic now. That's somebody who doesn't have other things, right?
So for non-syndromic hearing loss, they come in. Single most useful test is testing for connection. That's the most cost effective. And usually we don't do that. But then when that's negative, then you have the option of testing additional genes one at a time, or you can test a panel of genes.
So what do you do?
But the insurance, I usually would recommend a panel of genes because that's more cost effective. The insurance usually would pay that.
What's the purpose of doing it? What are you going to do differently?
Well, if you have a diagnosis, you can kind of predict what's the likelihood of the hearing loss progressing. That's especially useful for young families who want to have additional.
I see.
The patient comes in with this audiogram, headroom, low frequency, large conductive loss. Good otosclerosis case or not? Normal eardrum,
Normal eardrum.
normal impedance.
Still reflexes.
Good man. Get back. If there's no reflexes done, get them. So what does that tell you that they're reflex? A little bit of conductive loss, right, Matt? A little bit. That's all it takes, and your reflexes are gone, right? So what does that tell you that they're reflexes?
Well, it tells me the safety is normal.
Yeah. And what's causing, what kind of conductive or apparent conductive loss do you think it might be? Third window? Maybe?
It's like maybe more lower frequency loss with that.
Quite a bit of low frequency loss there. So, this would be a little bit severe for superior canal dehiscence. Any other thoughts about this? But that's the key point. When you see it, always look. That's the key outpatient point. All right, patient comes in, mixed loss, obvious otosclerotic, not yet had surgery. Do you treat with fluorides? Ears are getting a little worse each year. That bone line goes down. You see them every couple of years. Fluorides?
I haven't checked their water department to see if their water's fluoridated, because you don't want to give them extra fluoride when their water's fluoridated. But Fluorocal's been drug of choice for cochlear otosclerosis.
I know, drug of
Since
choice
I was a
is
little boy.
strong, but, because it's very controversial.
Yes, it is.
Any other thoughts? How many of you use fluorides?
I used it when I was younger, but as I got older, I used them less. And I was always concerned about, because they were using pretty high doses of fluoride. What's that doing to the metabolism of bone?
It's used for osteoporosis in women, particularly postmenopausal, but it can contribute to kidney stones, and certainly on an empty stomach it can give you a little hypochloric acid, there's no doubt. Yeah. Okay, I do use it occasionally. I'm not at all sure whether it works. I mean, the data originally came out of West Texas, where kids had model teeth from fluorosis. That's where the dentist recognized those model teeth didn't get cavities, and that's where we got the medication. They also noticed there was no stapes surgery happening in those communities in West Texas. They all went to Dallas for using it. That's really true. Okay, number one rule out, Reza. Where's Reza? Oh, Reza's not here anymore. Who's going to tell me Reza's not here? Johan, Reza's not here. You're Reza.
I would do a nasopharyngeal mass.
Right? Nasopharyngeal carcinoma, unless proved otherwise. Okay, somebody has nasopharyngeal cancer, they've been through radiation, they're NED, and they come in looking like that. Anybody put a tube in it?
I do. I know they continue to drain, but I think the tube does help them, even though they drain it.
I used to
I've
put
seen
it.
patients who don't drain.
I have some patients who don't, but I sure have some who do.
Yeah.
Right? Indeed, we've got one right now. Who, I told her I really don't like to put tubes in. Oh, please put it in. She begged me, and now she's just nonstop. Drainage, and I can't do this.
Mike Kaplan got on me for doing that, and I don't do that anymore.
As you know, we're also trying to dilate them. So we're trying to
Yes.
write the case
Yeah.
studies.
She went to Jennifer, and she has literally scarred shut. There's no Otology, let me just see where we are. We're going to talk. We have 1 minute, so the last thing we do is otalgia. Okay, you have a patient with otalgia of unknown origin. You examine them, their ear, and it looks normal. You felt their TMJ. How far do you go? Do you do CT and MRI? Do you do full endoscopy? What do you do for unilateral, unremitting otalgia with a normal ear exam and normal TMJ?
I go all the way.
All the way.
I need to find out.
CT and MR, both?
Yes. If I cannot find the cause of otalgia, I tell the patient either follow with me or keep repeating our tests. Let's see another second. I never tell them there's nothing wrong.
Oh, you never say there's nothing wrong, they're in pain.
Correct. So if I cannot find what's wrong with them, I send them to a colleague because I think there's something wrong and I just haven't found it.
25 years ago, I had a patient like that, and you remember that because you were up at UC and you saw her. And I got an MRI on her because she was a 70-year-old lady with pain, nothing obvious. MRI was reported back as negative. You took a look at the MRI and you found her malignancy in the base of skull of the clivus.
I remember her.
Yes,
and I remember her son was a lawyer.
I will never forget
years
that.
Ago. And the reason I remember it because it was I actually used that in teaching because I looked at the T1 and there was no clot in the marrow. The T1 without marrow, I suddenly realized that something was replacing. I think
She did.
But she had, it was replaced. It was not eroded, but there was no marrow there.
Right.
And that was the reason I picked up.
I never forgot
Well, it
that.
was so expensive, you don't see it as a piece. Sometimes if you're next to an elephant, you don't see there's an elephant because it's so large. So with that, we are now at 7. We're going to begin and end on time. And so I'd like everyone here at 6 o'clock. And I appreciate all of you. And you're taking the spirit that I put people on the spot, whether you knew or didn't, it doesn't matter. You're thinking about it, you're contributing, and we really appreciate it. So thank all of you for participating, especially today.